So I have been asked to talk about tailoring of antiplatelet therapy post-PCI. I have no conflict of interest. So why do we give prolonged antiplatelet treatment? Maybe the first thing why we give antiplatelet is to avoid late and very late stent thrombosis occurring, especially after the first generation of DS. Second point is to reduce the long-term risk of non-stent related myocardial infarction as well as stroke. Now, what are the risk scores validated for our dual antiplatelet therapy during duration? We have more or less two very good scores. These are the precise depth score and the DAPT score. We'll just try to give you an example and try to present a case of a 68-year-old myocardial infarction patient. This is his initial presentation. He has a normal right coronary artery, but he has an anterior STEMI, which I was able to stent by a long DES in the LAD. So this was a primary PCI for myocardial infarction in the first hour. The patient received clopidogrel and aspirin and heparin. He had no prior cardiovascular disease. He was a smoker, mild COPD. He had a mild renal disease at 48. So he was reperfused with a XANG stent. And yet, at the end of the procedure, the patient was asymptomatic. He had a normal ejection fraction. He was dismissed 4 days after his initial presentation. So I'll just try to calculate our scores for this patient. He has a DAPT score at 1. He has a precise depth score at 26. Now, which score to trust, because the two scores contrariate themselves regarding the dual antiplatelet strategy on the long run. The patient was doing fine afterwards. He visited me at 1 year and 3 months after the initial event. So I followed the recommendation. I stopped clopidogrel and continued aspirin along with beta blocker and statin. However, 5 days after stopping the clopidogrel, he developed a stent thrombosis in the LAD, which you can clearly see here. I was able to unblock the artery and to have a manual thrombectomy, then a balloon angioplasty by 3.5 balloon by 12 millimeter, and then IV agrostat for 24 hours. He had an optimal angiographic result after 24 hours. And I also performed OCT. The OCT clearly showed that there was a small part of malapposition, which I dilated, of course, by this balloon of 3.5 by 12. Now, what is the pathogenic mechanism of late stent thrombosis and very late stent thrombosis? Is it the uncovered strut? Is it the malposition? Is it the neo-arteriosclerosis? Is it the underexpansion? Is it all of them? Well, it might be all of them. Now, we have a new tool which is now available to us. This is the 2020 non-standing guidelines. And there is some important information within these guidelines, especially regarding the long-term dual antiplatelet treatment. As you can see, you have to balance the ischemic risks versus the bleeding risks in each patient. So tailor each treatment according to the patient characteristics. I will just refer to treatment after 12 months from the initial presentation. So as you can see, after 12 months, we can either go by aspirin or rivaroxaban. or we can either go by aspirin and ticagrelor, or aspirin and prasugrel, or aspirin and clopidogrel. This is for the low bleeding risk patients. Of course, for the very high bleeding risk patients, we have to do just eventually clopidogrel. I will put on the next slide. The 2020 non-STEMI guidelines state that double antiplatelet treatment for more than 12 months are a class 2A indication in patients at high risk for ischemic events and without increased risk of major bleeding. Double antiplatelet treatment is a class 2B indication in patients with moderately increased risk of ischemic events and without increased risk for major bleeding. So this is what the experts tell us. And here I inserted the risk criteria for extended treatment with a second antithrombotic agent. Now, we can have the risk enhancers, which are the diabetes, history of recurrent myocardial infarction, any multivessel CAD, polyvascular disease, premature or accelerated coronary artery disease, inflammatory disease, or renal function disease. Also, we can have diabetes mellitus, history of recurrent myocardial infarction, polyvascular disease, and again, renal disease. And what they included in these guidelines, they included the technical aspects, which were also present in the 2017 guidelines, but here they are more clear. So technical aspects that balance towards an increased risk for extended treatment with a second antibiotic agent are at least 3 stents, at least 3 lesions treated, total stent length of more than 60 millimeters, history of complex revascularization, so that means left main bifurcation stenting with more than 2 stents, and a history of stent thrombosis on antiplatelet treatment. I inserted here also the major and minor criteria for high bleeding risk according to the Academic Research Consortium for High Bleeding Risk at the time of PCI. So you have major criteria and minor criteria. And also on these guidelines, the experts show what are the treatment options for extended dual thrombotic or antiplatelet therapies. So here we have the drugs, the dose, and the indication. We have the double antiplatelet regimens for extended treatment, including aspirin 75 to 100, which can be rivaroxaban 2.5 milligrams daily. We have DAPT regimens for extended treatment, including aspirin 75 to 100. That is clopidogrel 75 milligrams, that could be prasugrel, that could be ticagrelor in post-myocardial infarction. What I forgot to mention is that we can also do, for the low bleeding risk patients, we can do ticagrelor alone. This is, we can introduce this measure after 3 months, starting at 3 months following a double antiplatelet treatment. So we can have also ticagrelor in monotherapy. Thank you very much for inviting me, and I am waiting to see all of you on the live Congress. Thank you.